grisly part to almost all good situations. So we got through our grisly part. So I was asked to come talk with you guys about adults and how adults learn and how they're different from children, because my guess is that most of the people you work with are at least chronologically adults. Okay, we may question, I'm not talking about your patients, I'm talking about your peers, and that chronologically they're all adults. And historically, adults and children, we've approached teaching adults and children a little bit differently, and there's a whole area of study dedicated to teaching adults. So we're going to talk a little bit about how they differ from children and how you can directly apply that to working with residents and fellows, working with students, working with each other, working with your patients. So I want you to think for a second about the person that you would consider to have been your best teacher. And it could have been in the last couple of years. It could have been way, 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 way back. I have to go pretty far back to get mine. But can you think of them for a second? And what made them so good? What was it?
I think the person I think of is patience. Sort of understanding why I couldn't understand what I couldn't understand.
Okay, so they were patient with you while you were learning, and they acknowledged that and identified with not having all the information. And that's one of the real challenges, especially when we see when trying to teach someone a psychomotor skill. After you've practiced it long enough, it becomes very easy to the point you don't even think about it. Have any of you taught anybody to drive in a long time? It's very difficult to be in a car with a novice driver because it's hard to remember all the steps that we went through to get to where we are. And what used to take us take up a lot of RAM in our memory, because we were having to think about the isolated, independent, discrete steps, especially driving a 5-speed and having to, let out the clutch and that kind of stuff. We don't think about that anymore, so it's hard to remember what it was like not to know how to do that. So it's challenging to be a teacher and to work with novices that don't know what you know. There's a phenomenon called the expert paradox. Have you heard that term before? And what it means is that you may be so good at something and so knowledgeable at something that it's almost impossible for you to communicate with people who don't know as much as you do. That is I'm paraphrasing, but that it's very difficult for you to understand and to teach someone because they're not at your level of expertise. We used to joke around about this in graduate school because I had a professor, Dr. Ludvigsen, and he is no longer with us, but was wonderful and very knowledgeable in animal learning. But as a teacher, we used to describe sitting in the classroom as the Lud-brain barrier. Wow. Because he was so smart and so knowledgeable in his content area, he had a very difficult time communicating with us. Now, if you read his journal articles, they're very easy to read, very easy to follow. But in a classroom situation, it was very difficult to grasp what he was trying to communicate. So remember that when you're working. So that's wonderful that you had someone who seemed patient enough and remembered what it was like not to know it. What else? What else would you use how would you describe your best teachers? Maybe things they didn't do too. Yeah.
I think of motivation.
Okay, so they found a way to motivate you.
To learn the material. Yeah.
Right, and how did they motivate you to learn?
Enthusiasm in the subject.
Okay.
And I guess the one I'm thinking of had the ability she was very good, but she also had the ability to get to our level.
Okay. So that ability to communicate at a level of expertise that's lower than yours, and to motivate you to want to learn. A lot of that motivation is helping you identify when you don't know something. So that's especially important to adults, is having that need to know. All right. So I'm sure we could go on and on, because when you start to think about these people that were so influential in your lives, you'll see, as we talk about the difference between teaching kids and teaching adults, my guess is that those are the people who really treated you like an adult learner rather than as a child. So what we're going to do today, we're going to describe the differences between pedagogy, which is teaching children, and andragogy, which is teaching adults. And we're going to talk about the steps in a model that I found that I think can be very useful for teaching people with different learning styles without even really having to identify what their style is. So how you can capture everybody without having to worry about he's a diverger, she's a converger. That's kind of fun to know, but you typically don't have time to do that. And you can apply this directly to working with other learners or with your patients. In fact, I found it in the patient education literature in nursing. All right. So I think it's easier to think about the contrast between pedagogy and andragogy in this chart format and looking at a couple of different areas within the teaching. They look at the learner differently. Okay, with kids, they're very dependent upon the teacher, and the teacher's responsible for what, when, how, or even if something is learned. All right? You remember this. I mean, what it's like, and those of you who have children in school right now, unless they go to Montessori school, Montessori does not follow this pedagogical model. All right? So I'm not endorsing pedagogical models because I happen to be on the board of a Montessori school, and even though I didn't go to Montessori school, I really appreciate that kind of training for children. But so that it's a little different than the pedagogical models. They also, in adults, we know that adults learn best when they're more self-directed, when they've got a say in what happens. And the teacher is, rather than just lecturer or director, they're the nurturer. We'll talk a little bit more about what that looks like. Also, the learner's experience is looked at a little differently. With kids, in pedagogy, we assume that it's tabula rasa, right? Everybody comes with a blank slate. We don't really look at their previous experiences as very important. They do gain from experiences of others, but for the most part, it's transmittal learning. I am telling you what you need to learn. All right? You'll begin to notice that what I am doing right now is more pedagogical than andragogical. Correct? We have created a system in medical education that is very pedagogical. We can talk more about that in a second, about what we might have to do to change it. Also, within adults, in contrast to the pedagogical models, experience does have a lot of meaning, and it's a great resource for learning. Did any of you have other jobs before you came to medicine or became a medical student? What did you do?
All kinds of things.
But you came, so you did other things. Many people come to medical school, they've been nurses, they've been EMTs, they've been school teachers, they've been bankers, they've been lawyers. People come, some of them come in with psychology backgrounds. Why would we assume that everybody comes in the same? And why wouldn't you want to tap into what they already knew so that they could better understand this new information and attach it to something? We know that when we learn, we have to figure out how to file that information somewhere. You need to attach it to other things. Otherwise, it's like a free-floating sticky note that's not very useful. We know that human memory and knowledge is a very interwoven, crazy, just complex network of information. Very rarely is something just an isolated factoid. So why wouldn't we want to try to link things on? It's kind of like when you get, if you're looking for something to wear in the morning, isn't it easier if your closet, like the shirts are in one place and the pants are in one place and the dresses are in one place and the ties are all hanging somewhere, as opposed to going to try to find that red shirt somewhere in that mess? Or in a file, it's a filing, analogous to a filing system as well. So why wouldn't you want to tap into what they already have as labels on their file folders as opposed to creating completely new ones? It takes a lot more effort. So much more learning is attached to, or much more meaning is attached to learning that you gain from experience rather than just sitting and listening. You know that most of your medical knowledge is linked to cases. That's what you remember. If I were to mention some kind of crazy disorder, I bet you a patient's face would pop into your head, because that's how we link information together. Also, then, learner readiness is looked at differently. With kids, it's predominantly a function of age. You learn certain things because you're in 2nd grade or because you're in 7th grade. I get this all the time because I have a niece and nephew in primary school, and I always know, I'm more attuned to it now because I hear how they're progressing through school. With adults, though, it's really based much more on a need to know. Again, medical education doesn't look like this. Medical education looks more like pedagogy. It's a function of where you are in your training. All right? Orientation's a little different for kids. It's predominantly subject oriented. You take language arts or science or social studies. But with adults, they learn best when it's life, task, or problem centered. Again, around cases, around expectations of what you're to do to perform in your job, so competencies even. And motivation for kids, sometimes you have to use a lot of external motivation with children to get them going, like star charts and M&Ms and those kind of things, but I suspect that no one's been giving you M&Ms lately for your good performance. So with adults, tend to be much more internally driven and internally motivated. Now, those external reinforcers don't hurt with adults. And it's a whole different talk. We can talk about behavior modification when you really need to use reinforcement. But for the most part, as learners, we don't need that. We're driven by that need to know, to be better at our jobs, to take care of our patients, to do what I do, to come talk to people. So it's much more internally driven.
So why do they insist upon these endo rotation evaluations all the time? You know, I mean, why are we, that's external, right?
Why do they,
Why do
they is the
program,
ACGM,
yeah.
ACGM, well, no, that's ACGME requires it. That's why the program requirements.
That's
And you're talking about evaluations. These are evaluations for the learners. That's to give them formative feedback, which is critical for them to know how they're doing, to know what not only what they're not doing well, but to know what they are doing well. So it's a critical part of the reinforcement and motivation system. So that's why that's built in.
And do you think that works?
I think they can. I'm not sure all of our evaluation tools are good enough to be doing what we want them to do, especially if they're just numerical, because they don't give you a lot of information about what it's going to take to improve your performance. That's why I think the written parts of those evaluations are probably the most important part.
The most time-consuming.
Absolutely the most time consuming. But they're the ones that actually give the learner information about what it takes to succeed and to hone their skills. So what I want you to take away, if you take nothing else away today, is that adults, our pediatrician friends will tell us over and over again that children are not just little adults. Adults are not just big children when it comes to learning. So we really need to shift how we think about it, especially since it's so much a part of the culture of academic medicine, to teach people like they're kids. I suspect most of you spent the first 2 years of your medical training in a classroom, maybe a lab, but a lecture hall. That is not andragogical, unless you had really dynamic instructors who made it very interactive and kept you engaged. So there are ways to do it in large groups, but it's a challenge. All right. So that's that part, and I'll leave you with that. And to be able to think about, before we talk a little bit more about learning styles, to think about then as you're building in learning opportunities for whatever groups that you work with, whether it's students or nurses or other staff members or fellows or your patients or your kids' PTA, that if you're dealing with adults, you need to think about how to treat them the way we know they learn best. And we talked about that they need a need to know. What's the fastest way in medicine to create a need to know?
When you have a clinical problem.
You've got a clinical problem. You have a case, right? You've got a case you need to solve. That's exactly what you need to try to do even in the first 2 years of medical school. Have any of you experienced a problem-based curriculum where they start very early with medical students, and rather than having them just sit in classroom all the time, it's small group and they get cases and they kind of learn around those cases? Yeah, they're very time intensive, but they're very self-directed, very high need to know very early on. The students are very motivated in those curricula. It's very interesting to watch those if you ever get a chance to sit and watch one of those things. I was lucky enough to get to be involved in the creation and kind of implementation and got to facilitate some, and it was wonderful. So, and many of those are very successful physicians now, which is nice to see. So be thinking about ways that you can tweak what you currently do to create that need to know, to tap into what they already know. Don't assume that people come in with all the same content knowledge. Especially, I think on the MCAT, and none of these are criterion reference where everyone has to know the same amount of information, right? if I score 75, get 75% of the items right on the MCAT, and you get 75% of the items right on the MCAT, how much overlap is there in our knowledge that we can guarantee? Not much. Same way on step exams. There's just not. They're not criterion based where you have to know 90% of a certain category. We haven't gotten there yet. I don't even know that we're moving that direction. So remember, not everybody's the same, but try to tap into what it is that they know, whether or not it's from their medical knowledge or from having had a job outside of medicine. Okay, so if it was only that easy and all we had to think about was the difference between adults and kids, right? But it's not, because not all adult learners are the same. I bet if I were to take any kind of learning style survey, which there are hundreds out there, and gave it to this room, I bet you we'd get a pretty even distribution across the different styles. We'd like to think, and there are some specialties in medicine where they're more of one thing than another, all right? And I bet you can figure out which those are. So if it only was that easy, we have to think about people's learning styles. All right, and a learning style, it just refers to the way people, they process information. There's not one good style, there's not one bad style, there's not one that's faster or slower, they're just different, okay? So individuals tend to gravitate toward a particular style of learning based on past experiences, even heredity, environmental demands, reinforcement. My guess is that you adapted a style, you probably had to tweak your style a little bit between high school and college. You probably honed that style in college to where it was kind of a well-oiled machine to get through school. You probably had to tweak it a little bit for medical school. My guess is residency program, you had to adapt a little bit differently to that. And you may change even more over time. They're not static. And for the most part, we bounce around between styles that work. There will be a dominant style, but you learn to be flexible to meet the demands of your environment. Again, as I said, there are hundreds out there. I'm going to just focus on one. I don't want you to get bogged down in the details of this. It's just an example to think about. But back in 1984, Kolb identified 4 styles of learning as part of his theory. He talked about divergent learners, assimilative learners, convergent learners, and accommodative learners. And again, don't let this intimidate you. There's not a quiz on this. I just wanted to show you the way he plotted this out, that there's typically a flow of processing where we start with concrete experience, reflective observation, move around to abstract conceptualization, and then finally active experimentation. And so people will fall in one of these 4 quadrants for the most part. Okay, some people are kind of on the cusp, but for the most part, that's how it works. So I wanted to show you just an example, again, without getting bogged down into the names and the labels, because I don't like those labels. I worked at a company here in town that produces tests like this, and they made us put our scores like on our cubies, our nameplates and stuff, and so I really got tired of labels like that. This is a company that happened to have passed on the Myers-Briggs way back and are still regretting it. And so every other one that comes along, we all have to take it and post our, so anyway, I don't like those labels. But here's an example of changing a flat. We'll do a non-medical one, and then we'll talk about one that may be more applicable to what you do. So the converger would prefer to hear about how a jack works and then try it. Maybe watch somebody do it and then do it. Okay, that's a converger. See if you can figure out kind of where you are. Okay. Oh, that's right. Does everybody know what? You may not have ever had to change a tire. You have a flat, you call AAA, right? So no. Okay. Yeah. A diverger would rather have someone talk them through changing the tire as they're doing it. Just let me start and talk me through. Okay. An assimilator would prefer hearing about the principle of using counterbalance to lighten an object and then reflect on how to use that information to get a tire off a car. I know one of these. It's a what? A consultant? An accommodator would rather just jump in and see if they can change the tire using a jack. They never look at the instructions. Ever. Okay, let's get one more closer to home. Okay, you're about to begin a teaching session with a medical student on a piece of respiratory equipment. All right, so this is a brand new medical student to your clerkship. Medical student wants you to demonstrate setup and give some background information first, and then they're going to try it. That's a converger. The next one wants to know if this equipment is like an air pump. They'd prefer you just walk them through setting up the equipment as they do it. That's a diverger. The next one was to bring home the operating manual so they can read through it thoroughly before they actually set up the equipment. You don't get any of these. That's the assimilator. And finally, you haven't even started the teaching session, but the learner's already puttering around with the equipment trying to see how it works. You know those. You've had those before, right? They're the ones that are messing around while you're trying to talk. That's the accommodator. Again, none of these are bad. It's just different. It's just a different way we interact with information in the world. And we've learned, this is a style we've typically learned. It's been reinforcing to us, right? It has gotten us through what we needed to get through, or we would have probably adapted or gotten out of medicine, right? So can you predict what styles are most common in medical specialties? There's a lot of literature out there, but the only one I really found that I thought was kind of funny was that 46% of surgeons are convergers. So it just gives you an idea. They process the world differently than you do. Okay? But what I want you to keep in mind, and especially when you're thinking about, you can apply this directly to patients, certainly. And remember, learning styles are not static. Somebody asked me just this week to go do a talk for a geriatric nursing group and wanted me to talk about learning styles in older adults, which is way outside of my expertise. But if you think about it, these learning styles may be something people carry through with them the rest of their lives, or it may be something that they adapt because their environment has changed around them. So again, that's way outside of my expertise. I don't know. I'm not familiar with the body of literature on learning styles in older adults. But I want you to keep in mind that for every group of learners, and it may be tainted a little bit in medicine. It may be more, like I said, with surgery, it's obviously heavily weighted with convergers. But for the most part, 25% of the population is going to fall into each of those quadrants. So if you approach a situation with your style, say you're an assimilator, you just just going to jump right in there and do it or whatever, you're going to miss the other 75%. The other 75% is going to be struggling to process that information because you're tackling it a certain way that doesn't really make sense to them. So what do we do so that you don't have to give a learning styles inventory to figure out what everybody is? Because I'm not about to suggest that you do that. You notice I did not bring one with me to have you do. I know people who do that. I hate it. So what are the implications for teaching residents, students, patients? How are you going to do this without, I like to think of it as a train. You need to figure out how everybody can get on the train. Which car is going to be marked for them and everybody can kind of get on and get on that knowledge train. Well, an educational intervention should begin with activities for the divergent learner, continue on for the assimilator, the converger, and finally the accommodator. That's that flow around that chart. All right? But again, after today, you can dump those names. We don't need those labels. I want to show you a way to remember this. So there's a sequence to it. And this is what I found in the literature, but I'm going to show you a way that I like because I know you guys like acronyms to see if you can actually remember it. So you need to connect to the learner's concrete experience. That catches the diverger. That's the first step. Now in geriatrics, give me something that's kind of, what's kind of a common, I'm thinking Alzheimer's, and I don't want to make that assumption. What's a common thing that you see in geriatric patients? Fortunately, I'm not there yet. Falls. So we're going to teach somebody about falls so that maybe even the family members, we're teaching a group of people. So you may have a bunch of different learning styles in that one group. You're going to teach that patient and their family about falls. So we want to connect to the learner's concrete experience. Have they fallen before? Do you know someone else has fallen? What happened when you fell? Describe the environment that you're in when we're in when that happened. So that's the concrete. What do they already know? What have they already experienced? When I talk to other groups about this, I use the example of diabetes. So do you know if someone just got newly diagnosed with diabetes? Do you know somebody with it? Have you had a family member? What have their experiences been? So find out what's already in there. All right? We're teaching them like adults. We're going to take advantage of what they already know, what that concrete experience. The next step is to then provide the logical information. So So then you say, well, you already know a lot about falls. Let me give you a little bit more information about it, about ways you can protect yourself if you do fall, and about ways of preventing falls. Some things you can do to move things around the house, some extra protection things that you can put in to keep it from happening, to make sure that you stand up slowly as opposed to popping up out of a chair, whatever it is that you do to educate your patients. You see how little I know about falls. I just exposed my ignorance. So you're going to start with what they already know, then you're going to add that other information that you want them to take away. Then give them an opportunity, any learner, whether or not it's a student or a patient, give them an opportunity to experiment with what has been learned. Have them practice getting up and out of a chair. Have them show you how they might rearrange a room, drawing it or moving around blocks or a model. If it's a diabetic patient, have them calculate their blood sugar. So this is where they practice what they've learned. This could be broken up too. It doesn't have to be all in one session. It could be, I want you to go away and go home, rearrange that room, and bring a picture back and show me what you've done. And then finally devise a plan to fit with reality. That gets that accommodator. So it might be the what ifs. Well, what if your blood sugar goes to 680? Okay, you're dead. But I mean, what if it gets really hot? What if you fall? What are you going to do? So kind of pull in some hypotheticals. What if things are a little bit different? What is reality when you get back to the house? Or even with your learners, if it's about falls and they're going to show you how they're going to rearrange this room, then they go home and rearrange one of their rooms. That's reality. Okay? So we catch everybody without even knowing what their style is, and not having to worry about what their style is, because we've given everybody an opportunity to get on that train. All right? So the way I thought you might be able to remember this, I know you like acronyms, so I came up with this acronym. I call it the PATH. This is the path to learning. So P is previous experience. What do they already know? That's that concrete experience. You're catching that first group. All right? The A is the additional information. So I've assessed what they have in their head. Now I'm going to tell them what else I want them to know. The T is try it. So that's giving them the opportunity to practice with that information. And finally, the H, how can I apply this to my world? All right? Does that seem reasonable to try? I would love to hear the next time I talk with you guys that you've tried this with some of your patients and some of the learners that you work with. See if you don't notice a difference with more people getting it the first time than having to meet one-on-one with a group to try to, because their styles are a little bit different and they didn't quite catch it the first time you were with them. I know with geriatric patients there are other built-in things that make it so that you have to repeat it over and over again. Believe me, I'm experiencing some of those things at 44. Not remembering why I went into the room to get something. I knew I went to get something, just don't remember what it was. So you may still have to repeat things, but you might find that's decreased because you've been able to tap into their particular style of learning and not having had them grasping at things and trying to process things in a way that doesn't quite fit with your own processing. All right? That's it. Any questions?
I have a couple of comments.
Sure.
The other thing, I love the PAD as a way to do it in a kind of in a specific session. If you had the opportunity to embrace students, residents, really, I did the Macy Harvard and they do the PBLs and everything, and we went into detail on that. Something that I try to do with the faculty in our faculty development about the geriatricians is using different settings where you can apply the same concepts. So you can use, what I can see using your path now is we do a session in the morning where we utilize reactivating prior knowledge and asking them.
You can use this as a
Exactly.
lecture format, right? So you build it into all of it.
But you can also use it in the bedside teaching
Absolutely.
with the patient.
Absolutely.
Which I think that's
Absolutely.
So it's a pretty portable thing.
Absolutely.
And the other thing that we have found is because we have experience from a third-year medical student and a resident and once in a while a fellow, then you will need to have similarly using the path model, how you call it, that is very practical, but in different venues, because we see that the medical student comes the first week and the understanding or knowledge of the geriatric syndromes evolve over the 2-week
Absolutely,
period.
absolutely. And I would think that learners, obviously we have a predominant style, but I would think that learners kind of move farther along in that process to where that they don't get as bogged down in the concrete experience part of it. The more familiar they are with the content area.
Exactly.
And I don't know
We
that
see
that's
that.
substantiated anywhere, but I would think that part of that then becomes kind of automatic that they do that on their own. But I don't know that. That'd be an interesting study to see if people over the course of a clerkship or a rotation kind of develop.
That's what we have seen anecdotally,
Yeah,
and we're
yeah.
trying to standardizing ways to evaluate the residents that were just ready to graduate.
Mm-hmm.
And what we did is we're involving in them in the co-teaching sessions that
Mm-hmm.
we are set up as called NICS geriatric retreats.
Mm-hmm.
And that's when you see them as an interns totally in this structure of learning geriatrics
Mm-hmm.
to the point we're able to teach and incorporate all of this
Right.
and maturing the way
Right.
they're learning
Right.
to a more like a preventive and moving to a very sophisticated level.
Right.
and
There's an evaluation schema that we can talk about
That would be
outside of this that I think you might be interested in that really looks at how learners progress that way. And I'll talk to you about, you may be familiar with it already. But I encourage you to try this. I think that's a very important point, that this is very portable, that it's something you can use at the bedside. It's something you can use if you're asked to do a talk, do it as a lecture format. If you're doing a case conference that's around a particular disease state or symptom, tap into what people already know. So see if you can. I think after a while this will become fairly automatic for you. I don't know if you noticed that I tried to do this too, because what is the first thing that I ask you? Tell me about one of your teachers, right? That's the concrete experience. And then I told you a little bit about adult learners. So I didn't want to jump right into telling you about adult learners. I wanted to talk to you about what you already knew about what makes a good teacher. So you'll find that it becomes habit, and it's a good habit. But I'd like to hear, especially when you're working with learners lower than you in the educational hierarchy, and then certainly with patients, to find out if this is something that you find useful. Okay. All right. Thank you guys very much. I think I'll
Thank you.
schedule to see you again some other time. I don't know quite when, but I look forward to it when I can figure out where you are.